Welcome to the latest in our series of TopMedTalks 2. In these podcasts, the TopMedTalk team is in conversation with global thought leaders in perioperative care. TopMedTalk.
Hello and welcome to TopMedTalk. I'm Desiree, Chappell, host and managing editor of TopMedTalk, and I'm joined by Monty, Mythen, editor-in-chief. Hello, Monty.
Morning, Desiree. Morning, Desiree.
Well, we're joined by one of our anchors on TopMedTalk who joins us frequently, Joff Lacey from St. George's here in the UK. Hi.
Good
Joff,
morning, Desiree. Nice to see you again. I'm very well, thank you. Yeah.
Where are you now, Joff?
So I am at St. George's Hospital in southwest London, and I'm in my final 6 months, eventually, of registrar training here in the UK.
And St. George's, that's your alma mater, is it?
Yes, in a sense. Well, so Nottingham was where I did my undergraduate, my medical training, but then I spent most of, as with our fellow guests who come to the moment, but my registrar anaesthetic training has all been George's based, with a few escapades every now and then. So.
You're finished up. Well, so, Joff and Monty, we have another guest sitting down, a TopMedTalk favorite regular, Tim Miller from Duke. Hi, Tim.
Morning, Desiree. Morning, Monty. How are you?
Great, thank you. How are you?
Very well. Enjoyed it again very much this morning.
Yeah. Well, guys, we wanted to sit and chat a little bit about, Tim, what you're going to be talking about today in your presentation. Intraoperative blood pressure and blood pressure management, intraoperative hypotension specifically, but also a little bit about the POQI 3 sessions and papers that have come out about that. So, can you tell us a little bit about what your presentation is going to be, what you're going to be talking about?
So, talking about the POQI 3 conference, so POQI, as many listeners to TopMedTalk may know, is the Perioperative Quality Initiative. Launched about 3 years ago. We've now had 6 consensus conferences. It's an international non-profit which looks to run consensus conferences and put out consensus statements on topics that we think, as the POQI board, are of interest. And for POQI 3, we chose perioperative hypotension, particularly blood pressure management, which I think is a topic which has received a lot of interest recently. One of the things you may ask is, why are we still debating this topic when we've been doing anaesthesia for hundreds of years? Why are we debating blood pressure? And I think we've really, since we've been able to get big data, we've been able to delve a lot more into the problems, potentially, of perioperative hypotension. And a lot of work, particularly coming from the Cleveland Clinic, as mentioned in this previous session, talking about the London Cleveland Clinic that's going to come. They've been really pioneers in using big data effectively, and one of the ways they've done that is really to look at particularly intraoperative and now a little bit of postoperative hypotension and the association with hypotension and adverse outcomes. And we really set up the POQI to get a group of experts to London a couple of years ago to debate this topic, and the manuscripts have now been published. They were published in the BJA in May of this year. Went online at the beginning of the year. With some cover art and all 4 manuscripts in the same issue of the BJA, and they've generated a lot of interest, which is great. And they're going to speak a little bit about what's in the manuscripts this afternoon, and then really open it up for debate.
Fantastic. So you said there are 4 different papers, and can you walk us through just a little bit of brief synopsis about each one of them? Yeah,
so the first one is the physiology of blood pressure, and Gareth Ackland led this group, and I think it really just refreshing, and we'd like to say refresh, but in many ways it may be learning about the physiology of blood pressure, and I think it's actually a fantastic paper and a really good read. And then the preoperative blood pressure, particularly how we manage blood pressure preoperatively, how we get a baseline. The use of 24-hour ambulatory blood pressures was something that really came out in that group, which I think I didn't realise how commonly that was done and how important it is to get a reliable baseline. A bit of our management of medications preoperatively, what we do with preoperative patients who are hypertensive particularly. No real evidence that we need to cancel. We may decide to an individual basis, but there's no real evidence that either lowering blood pressure acutely or cancelling for the majority of that patients is in their interest. And then there was intraoperative group led by Dan Sessler, who's done a lot of the work at the Cleveland Clinic, and really putting out the recommendations based on a lot of his data that it seems to be the association between a mean blood pressure less than 65, systolic less than 100 is another variable that's quoted in our recommendations because there's some data looking at that. It does seem to be associated with adverse outcomes, and we don't recommend having a blood pressure lower than that perioperatively. And even short durations, 1 to 3 minutes of hypotension, are associated with harm, and this is just associations.
Yeah.
But the evidence for what it is, we put out the statement that we don't recommend going below those levels. And for patients with preoperative hypotension, it may be that the threshold is higher.
Right.
Seems intuitive, although the data sort of is not granular enough to particularly look at that group. And then post-operatively, Matt McAvoy led the post-operative group, perhaps the hardest group to leave. It's undoubtedly, we all know blood pressure, hypotension, post-operatively is common. And so Dan Sester's now got some work showing how common that is. It's probably associated with harm. But the data is not really there, amazingly. So Matt did a fantastic job just outlining the challenges and the opportunities, particularly around monitoring post-operatively. And I know we've discussed previously on TopMedTalk that a lot of times patients go to the wards, the floor, and the amount of monitoring they get falls off very quickly. And we go to 4-hourly blood pressures very quickly in patients that have had major surgery. And as patients are going home sooner after major procedures, will the hospital environment change? So if you're in hospital, you're monitored.
Right.
And I think that is going to be the hospital of the future. And that was discussed at length in this manuscript. So lots to discuss, lots to debate, and I think there's going to be more studies coming out looking at blood pressure as the door's been opened into how this can potentially affect outcomes.
So one personal comment I'd like to make is I had my ambulatory blood pressure measured recently through my GP, because since the first time I had an arterial line put in, I was allegedly hypertensive. And based on the traditional one-shot blood pressure cuff, I'd be on triple therapy now. Ambulatory blood pressure measurement, I'm not hypertensive.
Interesting.
So I'm drug-free from that perspective by engaging with the opportunity through my general practitioner to have ambulatory blood pressure measurement done. It's routinely available in the UK, so, thumbs up for that.
And how was it, the experience of having it on for 24 hours?
It's a bit weird to begin with, they said... Other people said to me, you should go and lie in the garden or something like that. I had a full-on day because I thought there's no point in knowing what your blood pressure might be if you have a
when
day
you're
off.
sunbathing,
I had a crazy full-on day, and I didn't modify any of my traditional practices, and I am normotensive, allegedly.
Is it every 5 minutes? Or every...
No, it's longer than that. It's longer than that, and it varies over time, and you can take it off after a period of time, but it's just a regular, what looks like a regular blood pressure cuff. It's better fitted than a regular blood pressure cuff, and it works well.
Tim, on that note, do you know in the U.S., is this a common practice for GPs to do ambulatory monitoring?
I think it's becoming that way, but I don't know if it's used as much as it is here. My brother's a GP down in Bristol in the UK, and again, standard of care for doing that over in the UK.
I never hear, I don't hear about it much.
But we don't use it as part of a routine pre-operative workup. He uses it as part of management of chronic hypertensives, but
correct.
But in terms of trying to work out targets and baselines for the pre-operative population, it's not used commonly, and maybe that's where it should go as well.
It's exactly, maybe, but it's probably the gold standard, and that's what we put in the manuscript. In reality, where I am at Duke, we use Epic. And I really encourage all our residents, if they haven't got a 24-hour ambulatory blood pressure, which they often don't, to use Epic. So through Epic, you can go into what's called the graphs function, and you can see every blood pressure measurement that's been taken over the last 5 years for that patient. Mm-hmm. And many of these patients have frequent blood pressures taken, so you really get a good idea of what their baseline is, and it often is quite different to the blood pressure, obviously, that's taken on the morning of surgery.
Fantastic.
Another thing I'd like to ask Tim about quickly is, we'll be talking today about HPI, this predictive algorithm for hypotension that is in the operating room, critical care, the warning, the flag of hypotension is coming, that's now approved. Have you been exposed to that yet?
I haven't used it, but I've heard about it, I've looked at it, I've seen it used in models, but I haven't actually used it on a patient myself.
And we will talk about that a lot, particularly in the lunchtime session today. But you were the PI for a recent study, I think we're allowed to say this, of so-called AFM. What's AFM? We won't give any results or anything, but what's AFM?
AFM is using basically artificial intelligence to try and help assisted fluid management, basically to try and sort of having a help with your decision making, to basically give you information to try and help when you should give fluids based on stroke volume variation. So it's not a closed loop, it's a semi-closed loop sort of decision making tool that can help practitioners decide when to give fluids.
Is that in a preemptive, as in trying to, is that predicting that the patient is going to need it, or saying they need it now, out of interest?
It gives you, basically, the machine will tell you when it suggests that you could give fluids, and it's up to the practitioner to decide whether they're going to give fluids or not. And the study was looking at whether, using this technology, we were more successful at giving fluids at the right time. Because if you know from the Optimise study, which is the largest study so far of goal-directed therapy, only 30% of fluid challenges were actually successful, i.e. they raised stroke volume more than 10%. Using sort of machine learning, decision support, can we make that more effective, was the idea behind the study.
Yeah. All right, well, I hear the bells starting to ring, and Monty and I are actually on stage again.
We've got to get mic'd up.
So we got to get mic'd up and get out of here. So thank you so much, Tim and Joff. Thank you.
TopMedTalk. Nick Majerison here. Thanks for listening to TopMedTalk. Now, before we let you go, it's important that we remind you to subscribe to TopMedTalk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com, and click on the section marked email updates. Finally, TopMedTalk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on TopMedTalk. That's ebpom.org/meetings.